Hello and welcome to today's webinar on opportunities for early childhood programs to support the well-being of families during COVID-19 and beyond, made possible by the Robert Wood Johnson Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and the slides and recording will be shared publicly on chcs.org later today. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Armel Cazo, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, for starting us off and for assisting with the webinar today. This webinar is second in the series on early childhood and Medicaid innovation amid COVID-19. We are so grateful to the Robert Wood Johnson Foundation for their support for the Aligning Early Childhood and Medicaid initiative, which is focused on aligning state programs and investments between Medicaid and early childhood systems to drive more strategic, evidence-based investments for infants and toddlers in low-income families. This initiative is also focused on demonstrating the value of early childhood cross-sector alignment for improving near and long-term health and social outcomes. Our partners on this initiative are 0 to 3, the National Association of Medicaid Directors, Local Determinants of Health Consulting, and the Public Leadership Group. Next slide. Next week, we have the last webinar in that series that we encourage you to register for on our website. The webinar will share innovative policies and programs that were implemented to support the development and learning needs of young children during the initial COVID-19 response. Now I'm going to turn it over to our moderator, Kathy Botkin, who is a licensed clinical social worker and the Senior Technical Assistance Specialist with 0 to 3.
Thank you, Armel. And thank you for joining us today. This has been a year of changes, demanding flexibility from all of us. Even when we all hoped COVID restrictions would be brief and done by June 2020, it quickly became clear by April that families were experiencing extreme turmoil. Usual supports were absent when jobs were lost, childcare was closed, and social gatherings, even in parks and playgrounds, were shut down. While most every family felt distress, the COVID experience for families in low-resource poor communities was extreme. Organizations were challenged to find new ways to promote family well-being. Federal agencies such as HRSA and ACF encouraged new approaches. Medicaid and managed care organizations approved telehealth. National home visiting programs quickly sent out new guidelines for home visitors. We are all still grappling with the adjustments and the losses, hoping to use these lessons learned about community and wondering what lies ahead. In this webinar, the speakers will talk about opportunities to support family well-being, not just about enrollment and retention, but a deeper way of supporting families. There are certain themes in today's presentation: appreciating family strengths and respect for their input, discovery of new collaborations, seeing systems differently as we work away from our old physical offices, valuing shared data, and knowing that we must address equity, all of us together. Today, we will hear from 4 different program perspectives: from a national provider organization, an urban community agency, a state government, and a nonprofit rural agency. We hope to stimulate your reflections on new ways to align early childhood systems that support healthy families. Next. Here is an overview of the agenda, and I will be introducing each speaker very briefly. Their bios will be given to you later, but we want to maximize our time together. Please put your questions in the chat box as we are going through the presentations, and then we'll pull those up when we have our joint Q&A. Our first speaker is Dr. Sherry Alderman, a developmental behavioral pediatrician with an MPH and an endorsement in infant mental health. She is the ACT Early Ambassador for Oregon and chair of the American Academy of Pediatrics Council on Early Education. Sherry?
Thank you very much, and thank you everyone for joining in this webinar. This is a fabulous topic. I'm so honored to present the information that I have to contribute. I am pulling a lot of the information from the interim guideline that the AAP has authored to support families and infants and young children and adolescents through this emotional challenging time. I also have resources available at the AAP Council on Early Childhood toolbox that I'd encourage you to check out as well. Those links should be available for you. The toolbox is just a short list of the very best resources, all available free online for professionals, early childhood professionals, for parents and caregivers, and for young children. Each one of those categories also includes self-care specific to those audiences. Next slide, please. Next slide, please. One of the most challenging aspects of this pandemic that we are all enduring together is the unknown. From the very beginning, there have been so many unknowns. And one of the biggest unknowns that we are thinking about as infant and early childhood professionals and parents and caregivers is what impact is this having on infant brain development? We don't have the answer for that. We don't know yet what the impact of isolation is having on preschool-aged children who are developmentally so primed and ready to reach out to adults beyond their families to explore and learn how to engage effectively with those adults and with their peers. They're not getting those experiences. And we don't know what impact these stressors that are now clearly chronic stressors are having on individuals, families, and communities, spanning economics, death. Unfortunately, there have been a lot of families who have experienced death in the family, the fear that we all feel with the unknown, and that the violence that we're seeing and the hatred that we're seeing as well. Next slide, please. So infants and young children reflect and internalize the climate and conditions of their caregivers, families, and communities. They're kind of the canaries in the mine. And that we can learn from that. We can respond to that information that infants and young children are showing us when we understand that and prevent adverse internalization of that. Next slide, please. So we can lean into those basic infant mental health principles. We can read and respond to a child, an infant or a young child's cues. We know that under stress, those cues can be difficult to understand, but as the adult, we can work very hard to try to understand. And sure enough, if we don't get it right, they'll let us know and give us another chance to interpret what they are doing their very best to communicate. The changes that behavioral changes that can happen with a child, an infant or a child under stress is that it can impact their sleep, their feeding, their stooling, and their emotional regulation. And that's where they really reach out to us, and we wish that every infant or young child has an adult who is available emotionally and can be emotionally regulated to engage with that child effectively. We also expect that under stress, children will experience developmental regression. We know that this is transient, but it is real and it's to be expected as well. And some children will withdraw, and even infants will withdraw. And we want to be aware and ask the question, is this quiet child actually suffering as well? Next slide, please. So we also talk about a lot in infant mental health about the parallel process, because we know that caring for the parent or caregiver is caring for the baby. To address these stresses and challenges that infant or young child's parent or caregiver is experiencing will protect the infant or child from those stressors. So we look at social determinants of health and how that's impacting the family or community. We look at mental health. We look at how we can have safety and resources available in the workplace. And we lean into infant and early childhood mental health consultation, all ways of supporting the parent or caregiver to be able to be emotionally available and be able to support the infant or young child. Next slide, please. So what we can do, given all of the unknowns and all of the stresses, what we can do is we can hold to routines, perhaps make some new routines while we're all self-isolating at home. We can really take this opportunity to teach children about those family traditions and exercise many of those family traditions. And we can share stories. Children love stories. Even babies love to hear the voice of their parent or caregiver telling stories. And that's also a very valuable way of conveying family values. Also, we, as caregivers, parents and caregivers of young children, it is our duty to censor information and not expose infants or young children to some of the information that is out there and available. And we want to think about rephrasing what it is that we do want to message for that young child. It's a friend of mine with fully good intentions was in reinforcing that a young child to not hug her grandmother because she could make her sick. And we could rephrase that as we, not the child, but we, the child and the parent or caregiver, are keeping grandma's bubble healthful. So it becomes a positive thing and a bit easier to process and easier to reverse when that time for revisiting and repair comes, which it will in the future. So we want to be careful about framing information in conversations. We want to watch and listen and answer questions in a developmentally appropriate way when a child does ask the questions. They're asking their question. We want to admit when we don't know and be comfortable with that so that the child feels comfortable with that. And we want to empathize. We want to name it to tame it. You're frustrated that you can't hug grandma. Next slide, please. And for all of us, we can delight in the child. We can play with the child, and we can imagine together. Those are very refreshing, therapeutic approaches to engaging that we can all appreciate, and express hope and a desire in a positive light. We want to message to that very young child absolute safety and protection. Now, we adults say, well, we would qualify that, but for the child, they need to hear the message that they will be safe and protected, and we will always do our very best to do that. Self-care is very important as well. We want to take care of ourselves to be able to be available for children. And we need to look at developing trainings and strategies for recognizing and responding to stages of grieving losses, because when that families are experiencing that and young children will be going back into school and showing those behaviors as well. Next slide, please. So thank you very much.
Thank you, Sherry. That was wonderful and gave us a lot of things to think about. Now we're going to move to the Families First in Boston. And we have Magda Rodriguez, who earned her law degree in Columbia and is director of programming, and Maureen O'Brien, a developmental psychologist and who's director of curriculum and training and an author. Thank you, Magda and Maureen.
Hi, everyone. Thank you. We're going to tag team this a little bit. You'll hear from both of us, but we wanted to begin by letting folks know, first of all, thank you for including us in this delightful symposium of voices. And there were some threads that Sherry already identified that we will echo, which includes caring for the caregiver is caring for the baby. That really resonated with us because we really believe parents are the ones who have the power to shape their children's futures and, importantly, also make their communities stronger. So we'll start with that. Next slide, please. And you can skip our pictures. Thanks. So our vision as an established 30-year nonprofit that has operated in the greater Boston area for a generation and a half now, is that especially in early childhood, which is our current focus for the last several years, every parent needs to be strong and supported. Every child, therefore, needs to be thriving and resilient. And we also really believe that every community benefits from this power of parents. So we have a multi-layered approach to how we support parents. And it's a very parent-focused, equity-driven, parents at the center kind of a philosophy. Next, please. So, like I said, we operate on multiple levels as an organization, and Magda and I play different roles within the organization. And so we use community-based cross-sector partnerships to do our work in neighborhoods. And while we are in the greater Boston neighborhood, we are looking to expand. The first layer is what is our direct layer that Magda is going to speak to in detail in a moment, where we really talk to parents and caregivers about how can they fully engage in their child's learning and development. And we think very holistically about development using the Strengthening Families framework. The second level at which we operate, which is a bit newer to us and very exciting, is that we work and partner with parents to bring their lived experience to advise and improve the local institutions, such as childcare facilities, et cetera, around them, and also the policies in early childhood that are vital for their children's success. So they're the lever, and we help them with that. Next slide, please.
Thank you, Maureen. And again, this is an honor for me and representing Families First to be here today. And Dr. Sherrill really set the stage for us thinking and talking about parents. So Maureen talks about our vision and what we do. So what is our approach at Families First? We have two main programs, the Power Parenting Program and the Parent Leadership Program. We also offer additional services to our alumni, and we connect with agencies to really connect families to support. And we have these programs and services because we believe that if we have positive parenting education and support, we have leadership opportunities, we really can have a sustained impact across families, communities, and systems. Our Power Parenting Program, it is a 12-group session. It is led by expert facilitators. And we, and Dr. Sherrill again mentioned some of the topics that we talk to our parents, such as routine, self-care, because we believe and we know that this is important for families. We also connect families to resources and support within our communities. Then, we have a parent leadership program, and we invite parent leaders from the Power Parenting Program, but also parent leaders in the community. We engage them for 9 months. We offer them trainings such as parenting advocacy. We talk about goal settings, and then we partner with agencies to allow them to practice those skills with the partners and communities in some specific projects. Next slide, please. So we have been doing this for 30 years, and we knew that the role of parents was critical, but then COVID came. More than ever, we knew that we need to support our families. Our executive director, Sue Covey, really encouraged us to do something different. And during the first 2 months of the COVID, we gathered together And first, we conducted a need assessment to all of our stakeholders, but primarily we want to hear from parents. And all of them were saying, we need your support. We are at home, we don't have childcare providers, we need to be with our kids and we need tools, we need support. So that was really like an emergency call for us to really take action. So what we did during this first 2 months under Maureen leadership is that we pivoted to a virtual delivery. Our power parenting program and parent leadership program used to be in person, but we decided that we need to do it virtually and at a fast, at a very quickly pace. So we changed our model with the same basics and trainings, but now we are delivering it virtually. We added sessions and trainings about Zoom. So we were training our parents and our staff on how to participate in a very meaningful but interactive way. We also developed COVID-specific website materials and resources, and we made those resources available for all families in our community so they can check, have access to quick tips and videos to support them while they were at home with their children. And we adjusted the role that our parent leaders were playing before. They were supporting in the room, setting the room, but now we changed their role and now they were helping us with the tech during these virtual training sessions. Next slide, please.
So Magda talked about the immediate changes that we made, in a mad flurry like the rest of you, to make sure that parents really still recognize that they were top of mind for us, that we were going to be there for them in every way possible. Then we took a bit of a pause, a bit of a breath once all of our programs were running and said, what else do we need to do as an organization to sustain this? And we have outlined here the 5, we think, biggest steps that we took. The first is that we really created space for our internal staff to themselves process and prioritize essentially the trauma that we were all going through together. That included the parenting educators who normally would be in the communities where the parents are. They got extra sessions. We consulted with someone to help them think about their own mental health as well. We knew it was going to be a long haul. The second thing we did was we always worked with partners that assisted parents with their concrete resources. However, we knew we had to step up our game, and our parents were telling us that they really needed more. And so Magda and the team worked with the partners to solicit additional funds, mostly gift certificates for groceries, and to make sure that we were providing a bit more wraparound services to the families with whom we partner. The third one that really kind of happened and we discovered needed to happen was that our partners, our community partners, also needed to change their role a bit, because now that things were not on site, we all had to adjust our roles and sort of up our game. And so they really took an increased role in recruitment and retention because they knew their families best. And we also on our end made sure, like Magda said, that our parent leaders were letting the folks know that the partners and us were working really closely together to offer quality programs. The fourth thing we did that was very important, I think, is to implement a communications plan and really let all the stakeholders know what we were doing, because you feel like you're operating in a vacuum in this remote environment. And so that included funders and donors and lots of others. And in that way, we held our first virtual fundraiser, and we were very pleased to see that it exceeded expectations. Next slide, please. So we learned if you build it, they will come, which we were very delighted about. We ended up running all 19 programs. We had 268 parents really engaged, and including 39 parent leaders. And like many of you, we found that our virtual attendance actually meant that more dads were coming, more partners were coming. We had better recruitment and retention. And the kind of feedback that we kept going was actually helping us to be successful. So for everyone, we felt like investing in our internal capacity made a huge difference. And also that, our audience had different needs, and we really had to accommodate to what the parents were telling us. Next slide.
So although, thank you, Maureen, although COVID, brought us many, many difficult things, and as we have been talking about, and we all know, there was also good and positive things that we learned. So from moving forward, we want to continue delivering virtual and in-person programs when we feel that is safe. We want to continue offering gift cards and financial support for parents. We want to continue having stress management sessions into our curriculum, and we want to have a continuous improvement. So our last slide, just to conclude, and this is just for you guys to know a little bit about our pathway for parent leaders. They start at the Power Parenting program, they go to the Parent Leadership program, and then they work in the community. And thank you so much for, for just inviting us again.
Thank you.
Thank you, Maureen and Magda. A lot for us to think about in terms of that pathway that you've developed, and really appreciate you sharing with us. So our next speaker, as we move across the country, is going to be the Michigan Medicaid Home Visiting Program, Maternal Infant Health Program. And presenting will be Janelle Troutman, who has a Master's of Science in Nursing and is a health policy nurse specialist for the Michigan Medicaid program, and Dan Thompson, a manager of the Perinatal and Infant Health section at the Michigan Department of Health and Human Services. Thank you. Janelle?
Yes, thank you, Kathy. So as Kathy said, my name is Janelle, and I will be walking us through these slides, and then Dan is going to be joining us during the panel discussion today. And you can go ahead to the next slide. Thanks. So I'm going to just start by giving a brief explanation of what the maternal health program is. I'm going to discuss a major innovation that occurred during the public health emergency. And then I also am going to share some evaluation or survey results with you all. So the Maternal Infant Health Program is Michigan's largest statewide home visiting program. It's a Medicaid program, and it provides home visiting services to pregnant individuals and infants. The program goals are to promote healthy pregnancy, positive birth outcomes, and support infant health and development. MHP services include an initial assessment, and dependent on the risks identified during that assessment, certain plans of care are put in place, and the program also offers care coordination, education, screening for things like depression or developmental screenings, referrals to services, psychosocial support, and really a whole lot more. The program is delivered by licensed professionals. That includes nurses, social workers, dietitians, infant mental health specialists, and also lactation consultants. MIHP, or Maternal Infant Health Program, is really a partnership between Medicaid policy and our MIHP operations team. So policy is in one administration and the operations team is in a different administration, but we work hard together to support our MIHP agencies. The MIHP operations team has program consultants, quality specialists, a data analyst, and other support staff. And the actual MIHP agencies or providers that are providing these services are housed in a variety of ways. Some are private, some are located within health departments, and others are connected to health systems. The program really does serve a substantial number of participants every year, and they do a great job. Next slide, please. So MIHP is a program, since it's a home visiting program, it typically has a face-to-face requirement for service delivery, and that's according to Medicaid policy. So over a year ago now, at the beginning of the public health emergency, we quickly decided to allow MIHP services to be delivered via telehealth. This was for the safety of both program participants, but also our MIHP providers. Medicaid was able to do this through a temporary policy change, and this policy is still in place now, and it will be until further notice. So back when this occurred, Medicaid and the operations team worked very hard to develop guidance for our providers. So that included things like requirements for documentation, billing, and reimbursement for telehealth services. Our MIHP agencies did a really great job adapting to this change. It was a time that required a lot of change in a lot of different areas of all of our lives. But the operations team also did a wonderful job supporting them during that process. Next slide, please. So after telehealth had been allowed for some time, we wanted to conduct a survey on our MIHP providers. So the goal of the survey was to understand what the provider experience was like delivering telehealth services, because this was very different from what they previously did. We also wanted to know whether telehealth is something that we should consider continuing after the public health emergency concludes. And we also wanted to better understand or draw out some program parameters that we would need to consider if we did want to put a permanent policy in place. We had mostly a qualitative survey. It was conducted electronically. We had multiple choice questions, but we also added a free text box with every single question just to elicit the most comments and feedback that we could get from our providers. We did this in November, which is a busy time of year, but we were really fortunate. Our providers were eager and they participated and gave us some great feedback and responses. Next slide, please. I want to share some of the survey results. The MHP providers reported positive themes. They also reported some limitations of telehealth. Some of the highlights of the positive responses we received were that most providers felt that telehealth did not reduce the quality of the program. They also felt comfortable providing telehealth services. Some providers even mentioned that telehealth provided a safe environment for participants to share sensitive information. For an example of that, one of the participants had her call when she was in the parking lot. I think she was waiting for an appointment on her phone, and she was able to share some information that she couldn't share if she had been at home surrounded by others she wasn't able to speak freely in front of. So that was a good positive that we got back. Next slide, please. Some of the limitations that were mentioned. Virtual visits should not replace in-person visits. This was pretty resounding from our providers. We heard that often. They stated that they also had a difficult time fully assessing the home environment. It was more difficult with telehealth to observe body language and also to observe caregiver-infant interaction. Providers also did note some inequity due to phone or internet access, and about half of them reported experiencing some type of technical difficulty at one time or another, and that was both on the provider side and on the participant side. So the survey was focused on providers and not program participants, but we did ask our providers about participant receptiveness to telehealth. And there was really a variety of answers for that. Many of them loved it and many of them didn't. So there were participants that would have preferred telehealth even without a public health emergency. And there was others that wanted in-person visits during the public health emergency. It just wasn't their favorite to be going through telehealth. Next slide, please. So lastly, I just wanted to share some lessons that we learned, which are mainly the parameters that we need to consider if we do want to move forward with adopting a permanent policy. We really need to consider and determine the appropriateness of telehealth within a home visiting program. We need to consider documentation. We want to consider equity issues related to access to technology. The operations team is wanting to look into some trainings or educational opportunities so that our providers can learn more about best practices in delivering telehealth. And we also want to consider how to allow for flexibility with telehealth. And that's due to both unique circumstances for participants, but also provider judgment and allowing them to decide when it does and doesn't make sense to provide telehealth. We have not decided quite yet whether we are going to adopt a permanent allowance of telehealth within the MHP program, but we are continuing to evaluate the impact of telehealth. And as time goes on, we just continue and will continue to support our providers and help them problem solve, which the operations team does a great job of. So that's all I have for my portion here. I believe Dan and I's email addresses will be shared later and a link to the MHP website, which has a lot of helpful program information.
Thank you so much, Janelle. That was great. And I know there'll be some questions about your survey. Next, we're going to move across the country to Colorado, and we have Elizabeth Buffy Trent Wolf, a licensed psychologist in Colorado and an infant mental health, has an infant mental health endorsement. She's currently the clinical director of La Cocina, a Latinx-led and Latinx-serving nonprofit mental health and social justice agency. Buffy?
Thank you so much, Kathy. I'm so excited to be here today to talk to you about our agency, La Cocina, and our use of mindfulness within our agency, which has been needed now, I think, more than ever. So you can see on this picture here of one of our staff meetings in a Zoom meeting that we had recently. Like many of you, we've had to shift our work to be virtual and remote. And just listening to the previous presenters, I'm hearing a lot of similarities in what this year has been like for us. And I'm sure many of you can relate to it as well. But the staff that you see here, this is most of our staff. We're a small nonprofit agency, as Kathy mentioned. Our staff is predominantly Latinx identifying and bilingual in Spanish and English, and all of our therapists are bilingual. You can go to the next slide. So La Cocina serves the Latinx community across the state of Colorado. We are founded, born and bred in Northern Colorado and housed in Fort Collins. We've been around for about 4 years now, so we've expanded quite a bit. Currently, we're serving 5 counties across the state and continuing to grow. And honestly, being able to use telehealth resources has helped us quite a bit in being able to reach more rural communities or folks who traditionally don't have access to services, especially in their native language. La Cocina is founded on foundation of liberation psychology and anti-oppressive frameworks. So within that, we partner with our community in the development of our programs so that we make sure that we're not maintaining oppressive systems that just don't work for this community. So our programs are developed both for our community and by our community, which promotes their success and their sustainability. So within all of this work, mindfulness is super imperative to the work that we do with Latinx children, with families, with community. Our teams have seen mindfulness just improve a lot of different areas of our work, including increasing awareness and perspective taking, which is so key to liberation work. It improves our emotional regulation, which we know is vital to supporting co-regulation when thinking about working with young children and thinking about working with families who've been through a lot of stress and traumatic experiences. It's also done a lot to increase our own self-compassion and grace, which, as we all know, is something that's been really needed over this last year. And I was hearing people talking earlier today about the importance of the parallel process, which is something we think a lot about. And we know that mindfulness benefits children and families. So in order to foster those benefits in our community, we have to first cultivate it within our teams. And so I'm going to talk a little bit about each of our programs and how we use mindfulness in those programs. So our Mil Días de Amor program is our infancy and early childhood program focused on those first 5 years of life. And our founder and CEO actually has a background in infancy and early childhood mental health as well. And you can see how these principles have just been infused throughout the programs in our agency. That includes a family systems focus, but also a focus on reflective supervision and consultation. And so we know that reflective supervision promotes the use of mindfulness, self-reflection, self-awareness, which are just vital to this work that we're doing. We also have a range of programs for folks who are over 5. That's our La Cocina 6+ services. That includes service at individual mental health therapy for individuals or families. We use mindfulness in a therapeutic context for a variety of reasons. One is for grounding. For example, for a client who might be reliving or re-experiencing a traumatic event, using mindfulness in that moment in the session can be incredibly powerful. In our groups, we incorporate mindfulness by beginning each group with a moment of mindfulness. And one of our longstanding groups at La Cocina Tu Pausa is actually a DBT skills group, and mindfulness is one of the core components of those 12 weeks. Another program we have at La Cocina is called Mind Over Border. This is our forensic mental health team and community outreach and organization team. And on this team, they talk a lot about the importance of the use of mindfulness in order to cultivate the ability to be present with someone who might be sharing their traumatic story for the first time in the context of doing a forensic mental health assessment for someone seeking asylum, for example. The last team I'll talk about is our Respiro team. And this is the team that provides respite childcare services to the children of adults that are seeking our mental health services so that those adults can show up to their therapy and be present in the session, knowing that their children are safe and cared for. Florecer is an aspect of this team, which is a program that was actually born in response to COVID-19. It's a mentorship program for Latinx youth in our community. You can go to the next slide. Something that we've talked a lot about in terms of innovations during this time is how do we use mindfulness, something that's been a core value of ours for a long time, to cultivate presence. And presence is something that is so important right now in this age when we can't be physically present with one another. How do you cultivate that presence over Zoom? What does that look like? What does that feel like? And we found that mindfulness is really key and vital to this. And obviously it's vital and foundational to the work that we do in liberation. So each of our team meetings start with a mindfulness, which brings us into the space together. Our team this past year has undergone mindfulness trainings and virtual book clubs. These have been really important to help us know and understand as a team, what is mindfulness anyway? Why do we use it? Why is it important? And how do we use it for ourselves and with clients? I've talked a little bit about reflective supervision. This is something that is infused throughout our programs. Everyone who works at La Cocina has access to individual reflective supervision and group reflective supervision. We also offer reflective consultation with other agencies outside of La Cocina. For example, home visiting programs or early Head Start programs that are serving Latinx and Spanish speaking communities so that these providers can have access to reflective space in the language of their hearts. And we found during COVID that access to Zoom, again, has helped us be able to provide more regular access to this type of consultation for folks who live in more remote or rural areas, like in the mountain regions. Intentional use of space is another thing that we've talked a lot about this year, and I'm sure many of you can relate to this idea of Zoom fatigue, COVID fatigue. I don't know about y'all, but working from home this year, I found myself being busier than I ever imagined with back-to-back meetings, no transition time. Sometimes I'm sitting in my chair for hours without having stood up and gone to the bathroom. And that's where we need to bring in more mindfulness, right? And awareness of what's going on for us, what's going on for our bodies, how do we take care of ourselves? And we want to be intentional about this space and the time that we're meeting together. So practically what that's looked like on our team is maybe we have a weekly staff meeting, but each week we know what the intention of that meeting is for. And we use mindfulness to invite us into that space with intention. And even one of the meetings we have designated specifically for reflective team process to give our team a chance to connect and share what's been going on for them and what it's been like to live in the world we live in right now. The last thing I'll touch on here is our use of technology and social media, which has expanded throughout this past year as well. Being able to host Facebook Live events and charlas or community conversations over Zoom to engage a wider range of audiences and bringing themes like self-care and mindfulness directly to the communities in their homes. You can do the next slide. So I'm going to share some quotes now from our employees, from a client, in terms of the impact of mindfulness for them. So one of our staff stated, "I feel like the mindfulness training that was based on the book was incredibly helpful. It allowed me to have a more in-depth understanding of what true mindfulness and meditation are. This has allowed me to feel more confident when discussing the topic with clients, making clients more receptive to the mindfulness techniques I introduce." Next. This is a quote from a client who participated in our DBT skills group and is a mother. "I'm realizing that where my pain comes from in my body, and mindfulness has helped me to focus, look at myself, and be in the present. When the dishes are dirty, I no longer care like before. Now I can think more about taking time for myself. Mindfulness has helped me with my health problems. When I do not practice it, all the pain begins." Next slide. This last quote is from a staff on our leadership team. For me, the gift of mindfulness is connected to generating self-awareness and seeing clearly. So besides wanting that for myself as a therapist, mother, friend, partner, and colleague, I also wish it on my clients. In turn, they often report that becoming more mindful and aware of themselves is the most useful aspect of therapy. In fact, it is liberating, because what a relief to become self-aware with compassion and loving kindness. Next slide. So lastly, I'll share with you kind of our thoughts about moving forward with intention after the pandemic. Obviously, we want to carry with us this ongoing investment in mindfulness, which is something we've always valued within our teams, for our clients, with our community. We know that it takes time to engage in mindfulness practice, and we've seen a large return on that investment. Another aspect is community engagement, which is also something we've always valued, and moving forward, thinking about adding in lessons learned from technology and engaging distant communities. Lastly, intentional use of time and space. We know that intention allows for more space to be mindful, and we know that mindfulness allows you to be more intentional. Those two work hand in hand. We also think about being intentional with our programming moving forward, our use of resources in a way that's sustainable for our teams and for our community. Next slide. Oh, yeah.
Thank you very much, Bobby, for moving it along for me. That was wonderful. I thank you very much. I was going to ask you if you could give an example of the use of a space, if you have a ready example of how that's affected your work. You talked about the use of space and time, and if you could give an example.
Yes, I think that comes up most in thinking about the space of our meetings, being mindful about the purpose of each meeting. What are we meeting for? I've heard this not just on our team, but in other teams that we consult with as well, that especially in the beginning of the pandemic, people started meeting more often. They were like, we need to connect and touch base with each other. And then they were just doing so much meetings and not being able to get their work done. And so I think being intentional about what is this space used for, space, I guess, in the theoretical sense. Right. And why are we here, and how can we be intentional about what we're trying to do together? And I think moving forward, space in a more literal sense of as folks are getting vaccinated and we're coming into the office again together, and how do we approach that transition back to being in person with intention, and not in a way that's reactive, right, to what's going on. And obviously we feel always a sense of urgency from communities we serve. I'm sure many of you can relate to that. How can we slow down, use mindfulness, use intention to respond to these needs in a thoughtful way rather than reacting to this sense of urgency or crisis? So that's possibly another example of that.
That's great. Thank you so much. And I want to remind people to put your questions in the chat box. We're going to move now into the question and answer period for a little bit. And you can see all of the presenters here and be reminded. I was going to ask Sherry while we were transitioning, how the interim guidelines that you indicated, and helped chair and form for the AAP, have those been sent out and to all the pediatricians? Could we reference those if we were a community organization and going to work with a pediatric practice, that here's some guidance from AAP too, and we'd like to work with you, talk with you about that? Or where does that stand now?
Well, thank you for that question. They are publicly available for all who wish to retrieve it. We have also had a town hall open to all the AAP membership, discussing them as well. You can download the document, and please feel free to share it with any people that you feel would be interested in it. So yes, they're absolutely available, and it will be revised as needed, but it's currently available to everyone. Yeah.
Okay, thank you very much. And I just wondered, I was going to move on to Maureen and Magda. You talked about your parents using their lived experiences. I know when we talked preparing for this, you were talking about your parent ambassadors and how you have sort of a further development even of how you use your parent leaders. But do you have an example of your parent leadership, the type of activities that they've done, or a story?
Yeah, sure. So I'm going to take that question, Kathy. So we, during the pathway, again, we have parent leaders during the Power Parenting program, and they usually mostly work on retention. They call parents just to make reminders and support them during our sessions with chats. During the fellowships, our parent leaders, they are emerging parent leaders after the Power Parenting program. They have been joined, for example, the Department of Public Health, and they were looking at family engagement practices. And what they were given feedback about how to make those meetings more family friendly, and looking at a lot of the website and tools. And lastly, our parent ambassador, which is the last phase of the pathway, we have parent ambassadors on our board. We have parent ambassadors who join our Diversity, Equity, and Inclusion and Belonging Committee. And we have parent ambassadors doing mentoring, peer mentoring to our emerging parent leaders. And also helping us with other projects, either evaluation or focus groups. So those are some examples of the roles that our parent leaders during the pathway they have been able to do.
You've used, not just parent engagement, but really honoring their experiences so well. It's just very impressive. So thank you for that. Another question that coming in is just really and this is for Janelle and Dan. You talked about you haven't made a decision yet about what you're going to do with telehealth and what the factors are. I wonder if you could talk a little bit more about the process of getting that survey out, and then what are the criteria or factors that would lead you to want to promote having telehealth as an option continuing forward?
Yeah, I can speak to that. Thanks for that question. I think it's tough when it's home visiting and it's such a personal service and relationship that I used to be a home visitor. I know how it feels to be sitting in somebody's house. And so I think it is tough to know when it's appropriate and when it's not, I guess. So a big part of that survey, and I worked with Dan and the operations team to develop the questions, but we wanted to draw out the things we need to consider, which, that list at the end of my presentation really is what we're still considering. I think the research on telehealth within evidence-based home visiting programs is still fairly green. So it's an area that I think a lot of people are jumping into, but there's not that much guidance out there. So yeah, but I think we will keep an eye out on what happens nationally as well. One of the good flexibilities that occurred was the federal allowance of telephone only and both audio visual. So it was helpful to have those options. And I think we want to see what happens with that as well, because that's helpful with equity as far as phone and internet access too.
Yeah, we had a couple questions about equity. I wonder if you, Dan or Janelle, have a comment. Then I'm going to open it up to other people too about the, going virtual, and also the distances and everything. The equity issue came big for all of us. So Janelle or Dan, do you have any comment about the equity access?
Yeah, it's a serious issue for us, obviously. I mean, like any state, we have our urban areas and our rural areas, and areas of immense poverty, and we have connectivity issues, like Janelle mentioned during her presentation, that impact how certain segments of the population are being served. And this is something that all the home visiting programs in Michigan, and I'm sure throughout the country, are struggling with. it's hard to get comparative data if you can't conduct an effective home visit because of whatever it is, just lack of resources, internet issues. So that's one of my concerns, that if somebody does study the effectiveness of this, how do they factor this in? The fact that,
Right.
you can't compare sometimes, because we've heard stories about, and Janelle alluded to this, about, just calls that either dropped or were just such poor quality that the visit just did not seem to be high quality. But on the other end of the spectrum, some of them were fantastic, and
Mhm.
people loved it or really did not like it at all. Seems like there was not much middle ground.
Right. Um, and part of it is out of control of the program. It's the lines and how they're they're laid. So it's not the family or the program. Other people have comments about the equity access issues that you experienced during COVID, or anything. Sherry, you look like you were going to say something.
Yes, thanks. I just would like to share just very quickly a project that I'm leading in partnership with the Oregon Child Development Coalition, engaging with the migrant seasonal farm working community. And it was so nice to hear the details of these programs here today that have a genuine engagement with parents. This project with migrant seasonal farm working communities, we are nurturing self-identified natural leaders in the community and supporting them in the ways that they see they can further their leadership skills and engage and be a channel of trusted and reliable communication to address the deep fear that, for multiple reasons, that this long history of marginalized community has endured, and with COVID as well. And so that's, this community empowerment model with the parent mentors, as we call them, build the skills to move their community in the ways that they see beneficial for families with young children specifically.
I appreciate you sharing that, Sherry. I think that all of these programs have looked at, how to engage community and empower parents. And we could go on talking. Unfortunately, I know we're going to have to end, and I have to turn it back to Armel. But Buffy, one of the things that's come through, and I think also the Families First has been involved in this too. But if there's any resources that you might have for parents that you have found useful for mindfulness, or for staff for mindfulness and support, or for home visitors, Janelle and Dan. People have been asking about that, and we would, be glad to send that out to everyone along with the slides. So I will ask you to send those to me, and we'll be sure that it gets out to participants because there is an interest. Okay. Thank you all very much. It was just very enjoyable working with you and hearing about all of your good work. So thank you very much. I'm going to turn it over to Armel now.
Thank you so much, Kathy, for moderating the Q&A, and thank you to the speakers for your great presentations, sharing guidelines to address infant mental health, program strategies to engage parents as leaders, the benefits, but also the limitations of switching from visiting to telehealth format, the equity issues with access to technology, definitely the importance of mindfulness and non-traditional forms of mental health, but all of that to really remind us that caring for the caregivers is caring for the baby. I love that sentence. That was a great way to encapsulate all of that. Please complete the brief online survey that will pop up on your screen. Your feedback is very important, so please take the time to do that. As you open up the survey link, we wanted to point out that there are resource slides as well as the speaker bios that Kathy mentioned that are going to be available at the end of the PowerPoint presentation that will be posted on our website shortly. Again, we wanted to say thank you to our funder, the Robert Wood Johnson Foundation, for supporting this work, to all our presenters for sharing their stories and programs, and last but not least, a big thank you to all of you for participating in this webinar, for submitting all of the great questions, and for all that you do every day to help families thrive. Thank you so much, and have a great rest of your day.